Welcome, everyone. Thank you for joining us for our Pain Awareness webinar. My name is Cindy Steinberg, and I am the Director of Policy and Advocacy for the U.S. Pain Foundation. Today, we're honored to be collaborating with the National Institute of Health, Helping to End Addiction Long-Term Initiative, or the NIH HEAL Initiative. Let's go over our agenda. After discussing a few general items, we'll begin by looking at U.S. Pain Foundation's Pain Awareness Month theme to spotlight the full scope of pain, demonstrate the need for better data, and raise awareness about pain research and its impact on the more than 51 million Americans who live with chronic pain. I'm going to then introduce our guests. We will be discussing pain research to find biomarkers that could predict whose acute pain will develop into chronic musculoskeletal pain, and then we'll take questions and answers. So the webinar is just for educational purposes only. Any views and opinions expressed in the program are those of the individual speaker and not necessarily the organization which they're representing. As I mentioned, we're going to take questions at the end, but feel free to type in your questions while we're going along in the Q&A box, and we will keep track of them and ask them to the presenters at the end. The webinar is going to be recorded and will be available to watch at a later date through our website at uspainfoundation.org. Every year in September, U.S. Pain Foundation has a robust campaign to really raise awareness about pain during the month. And this year we chose the theme of Solve Pain Together, Changing the Pain Equation. Our focus really is to convey the many factors that must be considered to solve pain: the lived experience, the role of healthcare providers, the importance of updated, reliable data, and the need for pain research to improve health outcomes. We invite you to continue to participate in our efforts by checking out our weekly articles, viewing and sharing our 2024 chronic pain fact sheet, which you can download from our website, watching and sharing our weekly health hack videos created for Humana neighborhood networks, which can be found on Humana's YouTube page, and reposting US Pain's social media content all through the month. And to find out more information about our campaign and join any one of these activities, go to uspainfoundation.org. So next, we're delighted with the opportunity to partner with the National Institute of Health, our nation's premier biomedical research organization that conducts and funds most basic life science research in the U.S., as well as research on enhancing health and reducing disability and disease. One large initiative at the NIH that came about because of a tremendous amount of advocacy is the HEAL Initiative. And that initiative funds both pain research and substance use disorder research. Since 2018, Congress has committed more than $500 million a year to funding these two large research efforts. We are fortunate to have Dr. Linda Porter here today, the Director of the Office of Pain Policy and Planning at the National Institutes of Health Institute on Neurological Disorders and Stroke, who will first provide us with an overview of HEAL. We're also delighted to have Dr. Laura Simons, HEAL-funded researcher, who will discuss her SPRINT study today, and Ashley McDonnell, a participant in the SPRINT study. As I shared earlier, I encourage you to type any questions you have into the Q&A box as we're going along. So let me introduce you to our three presenters. Dr. Linda Porter is the director of the NIH's Office of Pain Policy and Planning in the National Institute of Neurological Diseases and Stroke. She holds a bachelor's degree in physical therapy from McGill University and a PhD in neuroscience from Boston University. Dr. Porter trained in neurophysiology at Rockefeller University and joined the NIH in 2003, where her role includes coordinating activities of the NIH Pain Consortium and also co-chairing the IPRCC, which is the long name, the Interagency Pain Research Coordinating Committee. She co-chaired the development of the National Pain Strategy and the Federal Pain Research Strategy. She had a key role also in the initial development of the NIH HEAL Initiative, or helping to end addiction long-term, and currently is a scientific lead for pain research supported by HEAL. Dr. Porter has been recognized for her work through the President's Award from the American Academy of Pain Management, NIH's Director's Award, and the Emma and John Bonica Public Service Award from the American Pain Society. Following Dr. Porter's presentation, we're going to hear from Ashley McDonnell. Ashley is an undergraduate student at Notre Dame and has lived experience with chronic pain. Since initially being diagnosed with Ehlers-Danlos syndrome, dysautonomia, and tethered cord syndrome at age 17, Ashley has become increasingly involved in pain research as a pain research partner. She currently consults on multiple research projects that span digital tools to target sensory discrimination and pain, clinician burnout, and pain care team functioning, and enhancing shared decision-making in pediatric pain care. Ashley first became acquainted with the Stanford Biobehavioral Pediatric Pain Lab as a participant in the SPRINT biomarker study. And finally, we'll hear from Dr. Laura Simons. Dr. Simons is a psychologist and professor in the Department of Anesthesiology, Perioperative, and Pain Medicine at Stanford University School of Medicine. In addition to her academic responsibilities, she helps treat young people with chronic pain at Stanford's Children's Center. Dr. Simons' lab studies how to develop effective pain treatments that incorporate measures of health based on biological, psychological, and social factors. Her research also uses brain imaging technologies to better understand how chronic pain impacts children and their parents. Dr. Simons' long-term goal is to lead a robust research program to improve care for young people with chronic pain while mentoring trainees from diverse backgrounds in medicine, psychology, and other health professions. She is committed to enhancing diversity, equity, and inclusion in the research workforce, as well as improving health equity through her research goals. So I'm delighted to welcome all of you, and Dr. Porter, I'm going to turn the presentation over to you.
Thank you so much, Cindy. I'm really happy to be here and as part of Pain Awareness Week and the U.S. Pain Foundation's efforts to help improve communication with the public. I am off camera, but I think that's just fine. I'm going to share my screen and talk to you this morning about the HEAL Initiative and what it is doing for pain research. And then talk a little bit about why the topic of today of biomarkers is so important to improving how we manage pain research and how we understand it. And so let me just open up the slide set and I will get started. As Cindy mentioned, the HEAL Initiative was started in 2018 from a large allocation of money from Congress to address the opioid crisis, with the recognition that better management of pain, chronic and acute pain, was an important factor in really helping to reduce overdose deaths and leading to opioid use disorder and other complications from the prevalence of opioid use at the time. And so, all right, my slides are not advancing. Here we go. And so what I wanted to start with is just a little bit of background on the public health crisis of chronic pain and how enormous it is. So we know nationwide, if we look at public data, public health data, that we have 50 million adults who live with chronic pain, 25 million of whom report severe chronic pain on a daily basis. And of that 25, about 20 million, who have, excuse me, high impact chronic pain, which you define as pain that interferes with life. And we know there are a few bits of information here, which you're probably familiar with, but we know that women are more affected by men by pain and chronic pain and high impact chronic pain. We know that people who live in rural areas report pain more frequently and with more severity than those who live in urban areas. And this is most likely access to good care, good health care in general, but also difficulty with access to appropriate pain care and pain management. The bottom slide just shows you some of the factors with which chronic pain and high impact chronic pain can interfere with life. Activities of daily living may be difficult, social engagements, like sometimes folks will stop going to work. Some people can't go to school. And so high impact chronic pain is really a life changer. And so recently, chronic pain has surpassed most other, if not all other diseases, at least those that we looked at, as the most common reason that people go to a healthcare provider. So clearly the prevalence of chronic pain drives that, the severity and the interference with daily life drives that as well. We also know that there are more new cases of chronic pain than other chronic diseases now in the US, including diabetes, depression, high blood pressure. So these obviously are other also very, very prevalent chronic conditions, but chronic pain is top of the list for healthcare needs and for new cases. It's incredibly expensive to the economy as well as a burden to the individual who lives with chronic pain. So why is the situation so challenging? And there are a lot of reasons why good pain management, personalized pain management is so difficult to get it right. We can start on the right-hand side. Not everybody has good health insurance. Not everyone has health insurance that covers pain care. And not all pain interventions for good pain care management are covered by most insurance policies. Depending on where you live, it might be hard to get into a clinic or even into primary care where you can get good management of your pain. We also know that people from different racial, ethnic, cultural backgrounds can be more affected by chronic pain, partly because of the stigma that's attached in some situations with proper care for them. Sometimes, to some extent, how people from different backgrounds might respond to pain management or individual treatment. So again, the entire population does not respond the same way in any way, shape, or form to different types of pain interventions. Big problem is training for providers across the spectrum of disciplines, where, for example, in medical school, there are very, very few hours given in understanding pain and treating pain. And this is something that we've been struggling with for decades that hasn't really budged too much as far as improving education for providers. We also are recognizing that we have a problem with our research workforce in that many of our really talented scientists and clinicians are retiring, moving out of the field, and we haven't kept up with the pace of bringing new people into the field. So we're working hard to correct that through HEAL. We also The complexity of pain itself makes it tremendously hard to diagnose appropriately, to treat appropriately. And that because some of the etiology or the mechanisms that drive different types of pain conditions differ. And so they respond differently to different treatments. Many people will have more than one pain condition, and I think we'll hear a little bit about that from Ashley, or they may have pain associated with other chronic disorders. So really tricky to get the interventions right for the individual and to deliver them appropriately. lifespan, pain changes, your risk for pain, your response to pain management changes over the lifespan from early age up into later adulthood. So we have a lot of challenges here that we need to work with. So the HEAL Initiative is helping. This, as Cindy mentioned, it's an NIH-wide effort, primarily focused with leadership from the Neurology Institute and the National Institute on Drug Abuse, but with input from many, many other centers across and institutes across the NIH. So a really collaborative effort to getting the science right and getting it out to the communities. We're funding projects across all of our states and now have reached well over $300 billion in money spent on the HEAL Initiative. We have a couple of accomplishments at the bottom of the slide. FDA approvals for more than 40, if we look across the OUD or the addiction component of HEAL and the pain component of HEAL, to test out new drugs or new devices for pain management or for addiction management. And across both sides of HEAL, pain and OUD, we have more than 300 clinical trials, which are either completed or underway. So HEAL is now going into its 6th year. So many of the trials that we started early on are coming to completion, and we're hoping in the next year or so to get a huge amount of important data from that. So a slide with much information on it to help you understand the breadth of the HEAL Initiative on the pain research side. So this slide represents pain research through HEAL only. And it's kind of, if you're moving from left to right, you can see some of the programs in early, what we call preclinical research. So this is tissue modeling, animal modeling, early discovery for new drugs, to look at molecules that have good potential to become good pain management analgesics, only one component of good pain care. And then moving into the clinical setting, we see the colors change on the chart from orangey to blue as we get into human studies, where we've got devices that are being tested for pain care. Biomarkers are incredibly important and come in many different shapes, colors, and forms. I'll come back to that in a few minutes, and Dr. Simons is going to talk about her wonderful project on biomarkers. And then we move into the blue and purple, which tells you a little bit about the types of clinical trials we're running, and the indications or the interventions that are being used for different types of pain or in different populations. So we have early studies where we would be testing out new drugs. This is the EPICNet for safety. And then moving into what we call effectiveness trials, where you're comparing one intervention to another to see which is better for a particular pain condition or population. And then we have really targeted programs on clinical trials in children. That's called Kids Pain, where we're looking at better management in both the acute pain settings for children and in chronic pain, which affects children and often can go to continue throughout their life. Pragmatic trials are those that are done in big healthcare systems where we're checking an intervention that we can use broadly across a healthcare system. So it's not necessarily looking at the intervention, but how we get a good intervention into the healthcare system so that many people can benefit from it. We're looking at how disparities affect pain care, and also looking at pain management that is best for rural regions. For example, can we put telehealth programs into parts of the country where it's very difficult to get to a clinic? Very important for HEAL is that we engage stakeholders. In particular, and most important, are people with lived experience to help us inform what is most meaningful to them for outcomes from a clinical trial, how they can help us with challenges in clinical trials and make the trials more user-friendly, if you will, to put it very simply, but really helping inform us on how to do our trials better for you. Workforce enhancement, I mentioned, we need more people in the field to help us with our research over the future and to talk to one another across the spectrum of pain research. So we're working hard to bring those early discovery investigators together with clinical research investigators. And once again, to try and make sure that we get out of our trials what's most meaningful to those of you who are meant to benefit from our trials. Just a couple little points of interest here about some of the challenges for therapeutic development. So this is, the real exploration for new medications for pain, which has been driven for us to be more engaged by the fact that many of the pharmaceutical companies that used to do a lot of research in this area have dropped programs. They're expensive. The programs for new analgesics the safety issues are hard. A lot of reason that industry has dropped out. So the HEAL Initiative has tried to create like its own little pharmaceutical pipeline or companies built into our programs to move new promising molecules, natural products, all the way from the basic discovery into clinical testing and then eventually out into care. This slide is to give you a sense of the kind of pain conditions that HEAL is studying in the clinical setting. So this is all human pain studies, and they range from clinical trials to what we call observational studies, when you can look over time on how people are doing. This would include our biomarker studies. And you can, on the left-hand side, are the types of pain or pain conditions that HEAL is studying in order to improve pain care. And on the right-hand side are just the names of different programs that we are doing. I'll talk a little bit today about biomarkers, the Back Pain Consortium. Back pain is one of the most prevalent pain conditions in the country, in the world. And so we've got a big program going on there. And then we'll, just to let you know that these are the networks, the big programs, rural health, kids, that HEAL is addressing from many different avenues for understanding the pain in these situations and for improving the care. So let's talk a little bit about biomarkers and why they're so important and what they might look like. So biomarkers come in different shapes and sizes and can be applied or be useful for a number of different situations. So we have biomarkers that could help us in a clinical trial setting to know what molecules might be good or promising as analgesics or for pain relievers. Biomarkers can also help us to better understand how to measure pain in certain tissues. So a couple of examples here. We have a program on joint health, looking at biomarkers where we have an intersection between the nervous system and the musculoskeletal components of a joint. And so what are the kinds of markers that would help us understand that the nervous system has been damaged or traumatized and therefore leads to joint pain, or degeneration of the cartilage or bone in that joint that leads to pain, and how those things interact. And so therefore, how we might begin to, for example, reduce the progression of joint deterioration that's contributing to pain. So another set, if we move over to the biomarkers for painful muscle and connective tissues, we call this myofascial pain, and myo means the muscle part and fascial means the connective tissue part. And this is probably the type of pain that underlines many, many different pain conditions, like low back pain, shoulder pain, knee pain, that's sort of location specific, if you will, but involves muscle and its associated connective tissue. So we're looking for markers here, and an example might be you have pain in the area around your knee, and we can look at those tissues and say, oh, the muscles are less stretchy or elastic, and so that tells us that's contributing to the pain, or they don't take on enough oxygen. And so those might be the kind of biomarkers for like a particular type of pain in a particular type of tissue. Back pain biomarkers, and we're doing a huge program, as I mentioned, on low back pain. And that program includes looking at sets of biomarkers that will help us understand the profile of an individual who has a certain type of back pain, and why they would be more likely, based on that profile, to respond to a particular pain management strategy. So when we think of biomarkers in this setting, and Dr. Simons is going to talk more about this for her SPRINT study, we don't think that we're going to find one biomarker that can tell you that you have pain, that your pain is going to progress, or what kind of an intervention would be best for you based on your biomarker profiles. So we call this a biomarker signature, which could include a number of different characteristics. And I'll come back to this in a second with an example of a study on knee pain, knee surgery. And so in short, biomarkers can help us help us in the discovery process of new analgesics by what might make a promising analgesic. It can help us predict who has acute pain from an injury or a surgical procedure, for example, who is likely at risk to go on to develop chronic pain, and what are the signals that are going to tell us that. And then other types of biomarkers would be to monitor. So we have a drug, it's working in humans. We want to know why. And so is there something in the human itself, the person, that can help us understand why that drug is useful? So really quickly, we have a very, very big study going. This is outside of HEAL, and it is called the Acute Chronic Pain Signatures Program. So here again, biomarkers, we don't expect one biomarker, whether it's genetic or an inflammatory marker or changes in the nervous system, to be able to tell us much about what kind of pain a person has, what we expect, how it might progress, or how it might resolve. So we're looking at people who have a knee replacement surgery coming up, or thoracic surgery, and we give them a huge profile. We do brain imaging to see what their brain signals look like before the surgery and 3 to 6 months after. We're looking at other pain measures too, like how do they sense heat pain or pressure pain before and after. We're looking at how they describe their pain, how severe it is, how it disrupts their physical activity, where it affects different parts of their body. And then you go into the psychosocial characteristics, which turn out to be incredibly important in predicting how pain can progress or resolve in an individual. And these include, for this particular study, catastrophizing, depression, anxiety, early trauma, which could be neurological, psychological, physical, sleep, and disability. And then we're also looking at cellular type of markers. What kind of, is there inflammation in your system from the pain? Is there a change in how the genetics affects protein expression and things like that? And so what we expect to find from this is a collection of biomarkers and how we can use them to predict who's going to be better after surgery and who's going to continue to have pain. And so therefore, how should we treat them differently? And so to conclude here, one thing I do want to mention is that these studies are complex. The data that we collect from them is incredibly complex, and it takes an enormous amount of data crunching and to understand what the outcomes of all these studies are. And so HEAL also has a huge program to bring data together from across all their studies and help us better use that data to provide tailored or personalized treatments for people with pain. And so this is going back to the earlier slide of the challenges, and I hope I've been able to give you at least a couple of examples in each of these areas where HEAL and other sister agencies are helping us to better approach pain management through science and research findings. So what I would like to do now is to turn over the presentation to Ashley McDonnell, who is going to talk to you about her experience with research and pain. Ashley.
Hello, my name is Ashley McDonnell. I am a junior at the University of Notre Dame studying neuroscience and behavior. And I'm so honored to be here today talking to you about my lived experience with pain, and then also my involvement with clinical trials and my expertise as a patient partner. So I just want to give you a background about my pain journey. I first experienced stomach problems in 2020 and was diagnosed with small intestinal bacterial overgrowth. And then my problems continued to escalate. And I was experiencing some neurological issues. And after about a year, I was diagnosed with dysautonomia and Ehlers-Danlos syndrome. And so I'm incredibly grateful that I was able to see the multidisciplinary pain team at Stanford, and they were absolutely incredible throughout my pain journey. And throughout my entire experience, I knew that I wanted to give back in the future in the healthcare field. And so that's why I'm studying neuroscience as an undergraduate. But I wanted to begin to take actionable steps to working towards improving the entire pain field. And so that's how I first got involved in participating in clinical trials. So because I was being treated at Stanford, which is an academic institution, they reached out to me regarding involvement in some clinical trials. And so I first participated in the SPRINT study that Dr. Simons is going to talk about shortly. But it is looking at biomarkers for teenagers with chronic musculoskeletal pain. And so I was reached out to participate in that study. And so it's called the Signature for Pain Recovery in Teens. And my participation consisted of some sensory discrimination tests, a blood draw looking for those biomarkers, an MRI, and then surveys up to a year after I first went into the lab for my participation. And so a question that many people ask about participating in clinical trials is, why is it important to do so if you are not going to personally get the results? And that's a question I asked myself because it's so easy to want to completely distance yourself from the medical field when you're already dealing with hundreds of doctor's appointments and so many tests trying to figure out what's wrong and like the root cause of your pain. So I asked myself that same question: why would I want to continue doing these tests if I'm not going to get anything from it? So I really saw the opportunity to participate in clinical trials as a way to take lemons and make lemonade, because as a person with chronic pain, you're afflicted with this disease, and participating in clinical trials and being able to advance pain research is a really meaningful way to take a negative and turn it into a positive. And so that was truly my motivation for participating in clinical trials. And because I've been there, I know what it's like to be a patient with pain. I just want to advance this field. And so researchers need participants for these studies. And so you have the incredible opportunity to do so as a person afflicted with pain. And I want to talk a little bit about compensation, because I know that can be a potential like barrier. So things like transportation and funding are given. If you talk to the research team, they're happy to help break down any barriers to make participating in the trial available for everyone. So that's something I really appreciated when working with Stanford. And so I've also had the opportunity to further my engagement as working as a patient partner. And so I'm really grateful that there is such a strong push to bring patients even further into the research experience. And so Stanford created what they call a better panel, which is bringing everyone together to elevate research. And so I'm honored to be a part of that panel, and it consists of teenagers with chronic pain, their caregivers, and also researchers working at Stanford. And so together we have discussions about some of the research and trials that are going on and what we want to see as patients. And it's just an incredible forum to be able to communicate that to researchers. And so I've been able to be a patient partner for the past 3 years, and I've helped with grants, study design, collecting data, analyzing our findings, and even testing products. So it's really given me hope for the future of medicine, and I'm really excited to continue to talk about being a patient partner. But first, I'm going to turn it over to Dr. Simons to talk about the incredible SPRINT study before we go back to talking about patient partnership.
Thank you, Ashley. What a great handoff. I'm going to go ahead and share my slides here. Okay. All right. So I'm really honored and pleased to have the opportunity to present with you and alongside Ashley and Dr. Porter to discuss biomarker discovery for personalized pain care. Dr. Porter, thank you for such a wonderful overview of the biomarker program and all the efforts that are happening at NIH and HEAL to address pain. I began my journey in the field of chronic pain in graduate school. As a clinical psychology resident, the University of Florida began working with individuals with chronic pain, sharing space, listening to their stories of frustration, uncertain treatment pathways, and the stigma of living with a condition that is both invisible and treated by many as simply a symptom. I knew that I wanted to dedicate my career to helping individuals living with pain through clinical care and research innovations. 20 years later, I haven't looked back, and I'm continually energized by the work. While preparing for this important talk, I met with the U.S. Pain Foundation leadership, and Cindy Steinberg, who started us off today, said something that stuck with me. We've been throwing darts at the wall and seeing what sticks. As most of you know from your personal journeys, she was referring to pain treatment. Our understanding of what to target and how to target has been quite limited and has resulted in often long, windy routes in pain care. I'm going to talk to you today about our biomarker discovery study that was funded through HEAL and that Ashley provided a really beautiful overview of. We've been following 250 teens with chronic musculoskeletal pain over the course of a year. Some of those teens were able to conduct in-depth interviews about their pain care journeys. Here's the journey of one of our teens. Starting back in 2016, this teen depicted multiple surgeries and medical procedures to address the pain problem with tremendous frustration. Why can nobody help us? And it never lets up. And from our interview, they pointed out how the emotional component of their pain was being undertreated. This teen chose to depict their journey with a series of images to communicate their pain and struggles, noting that their pain is characterized by hills and troughs with pain spikes. Both of these young people in the study reported persistently high pain and impairment 1 year later. In contrast, this young person's journey denotes a more linear pathway from diagnosis to physical therapy treatment to regaining function and playing soccer again. And finally, this young person, diagnosed in 2021, had a journey that included a number of medical providers along the way: GI, neurology, cardiology, physiotherapy, and finally developed a treatment plan. Both of these young people in the study reported improved pain and functionality at 1-year follow-up. So, what if we were better at hitting the target? That is the goal of biomarkers. Although Dr. Porter talked about the biomarker program, I want to spend a few moments talking to you about what truly is a biomarker. It's a measurable sign in your body that says something about your health status. Blood-based biomarkers include proteins your body makes when there's an inflammation or an injury. Inflammation is a common cause of pain, so measuring these proteins helps us understand how your body is dealing with the pain or injury. Brain scans can show us changes in the areas of the brain that respond to pain. This can help us see the pain by watching how the brain reacts or is changed by living with pain that isn't obvious or on the outside. Body responses such as how your heart rate changes when you're in pain or stressed, or quantitative sensory testing that measures the sensitivity to things that cause pain, like heat, cold, and pressure. And salivary biomarkers, or SPIT, include cortisol, often referred to as the stress hormone, and can measure inflammation that we also get from blood samples. So what is the potential impact of biomarkers? They can improve diagnosis through precise measurement and potential early detection. They can personalize treatment through tailored therapies based on a person's unique biology and can predict how a person will respond to treatment, reducing throwing darts at the wall. They can track treatment effectiveness by monitoring treatment progress and potentially detect signs of relapse or worsening of pain-related symptoms. Biomarkers can inform prevention strategies by identifying specific biological processes that drive pain, like inflammation, and can even clarify different pain types, whether it's inflammatory pain, neuropathic pain, or nociplastic. These breakthroughs can lead to new drug targets, better clinical trials, and ultimately more precise and effective pain treatment. To further understand the role of biomarkers, imagine you're an archer aiming at a target in the fog. Every shot is a guess, and sometimes you hit, sometimes you miss. But now imagine the fog clears. Suddenly you can see the bullseye clearly. Each arrow you shoot now has a higher chance of hitting its mark. That's what discovering biomarkers can do for medicine. It helps us clear the fog so we can target treatments more precisely and accurately, reducing trial and error and hitting the right treatment with fewer misses. So I want to talk to you a little today about SPRINT, signatures for pain recovery in teens. This was an idea that came out of a few different meetings back in 2018 and early 2019 is when we first applied for funding and started the project in the fall of that year. This brought together a team of researchers in psychological science, data science, neuroscience, nursing, immune science, and anesthesiology. What we know is that pain is complex, and in order to really get the answers, we need everyone at the table, including our patient partners. So this was a partnership between individuals at Stanford, University of Barcelona, Cincinnati Children's, Toronto Sick Kids, and University of Toronto. I'm going to walk you a little bit through the journey of our prognostic biomarker discovery and the study. Even as I mentioned at the inception of the grant idea, we all came together to meet, bringing our knowledge of the field through reading many research papers, talking to colleagues, and for many of us, our firsthand experience of working with patients in the clinic. This informed the selection of the markers that we wanted to collect in the SPRINT study. We aimed to balance increased knowledge gained with the burden of the study visit for each of our patients. We invited teens who presented in the pain clinic for treatment at Stanford Children's Health, Cincinnati Children's Hospital, and Sick Kids Toronto to enroll in the study. They participated in a 4-hour visit that included a brain scan, measures of pain sensitivity using quantitative sensory testing, a blood draw, and completed a number of surveys to assess their current status. After the data was collected, we gave it to our brilliant data science team who ran models that examined how these markers related to one another. We then met again to talk about what do the relations among these markers mean in the context of our understanding of pain science, and from there we built our predictive models that I'll share with you today. Of note, the surveys that we used in this study are part of a larger effort across the HEAL Initiative and NIH to gather what they call common data elements, so that the data across studies and across cohorts can be combined, leading to further pain science discoveries. So if you find yourself participating in any of these studies, these common data elements should be represented and provide an opportunity to bring all of that information together in order to move the field forward more rapidly. So I wanted to, before I dive in, I want to provide you a bit of information about these sprint teams. We had about 70% of teens in our study identify as female, 20% who identified as male, and 10% that identified as gender diverse. We had the majority of individuals identifying as white and 12% Hispanic or Latino. As you can see here, the majority of the young people were older adolescents as part of the study, and is very congruent with what we know about the onset of persistent musculoskeletal pain in adolescence. And remarkably, I should note that about 2/3 of young people with chronic pain and musculoskeletal pain in adolescence continued to experience persistent musculoskeletal pain into adulthood. Thus, it's really wonderful to see work done in young people that can hopefully be a preventative strategy for lifelong pain and suffering. Our sprint patients had a number of different conditions. So diffuse pain, which includes fibromyalgia, localized musculoskeletal pain was our second largest group, and connective tissue disease, so Ehlers-Danlos, being predominantly represented there. And although not depicted here, what we saw is a high degree of overlap among these conditions. So we saw most people had at least 2 or more diagnoses when they presented for our study. And when we look at the pain spread, only 8% of the young people in our study reported pain in one body area, with over 62% reporting pain in 4 or more body areas. When we look at how individuals were doing over time on that 1-year trajectory, we saw that 53%, so more than half of our young people, reported high functional disability or pain-related impairment up to a year after enrolling in the study. And only 1/3 showed remarkable improvements in recovery at 1 year. Similar for persistent pain, we saw 40% of individuals reporting high pain intensity across the 1-year mark, with 30% reporting this kind of relapsing remitting picture, where they showed some improvements, but then showed a decline in function, and only 30% showing clear improvements. So what we know is that this is a really, even at this young age, we see a really complex clinical picture that requires a better understanding. So let's get to some of these results. When we examined our markers of persistent pain-related functional disability, we found that markers of distress and fatigue, sensory sensitivity, immune response, and brain responses were predictive. Key features to note is that these markers don't operate in isolation, as Dr. Porter mentioned before. They're strongly interconnected. So you can see those gray lines showing the relationship among these different markers. For functional disability, distress and fatigue were prominent predictors of persistence. As you can see by the size of those bubbles, that's how important they were to the predictive model. When we examined markers of persistent high pain intensity, we found that markers of immune response, sensory sensitivity, and brain response were predictive. As in the prior model, these markers are not in isolation, and they're strongly interconnected. For pain, the immune response markers were prominent predictors of persistence. And some of these markers can be difficult to measure, such as brain scans, but others are much easier, such as a blood test, or for sensory sensitivity, one of our most prominent markers was knee pressure pain sensitivity, which can be measured in the clinic. So these markers all together give us some information, some markers to begin to follow up on, from discovery to how they can inform treatment and individualized care. So where do we go from here? Well, the idea of this whole program is in order to apply an individual lens for patient-centered pain care. We can think of each of these pie slices as a set of markers that we can measure and then can directly inform treatment decision-making. So that when we look at the multitude of markers, thousands that were in our model, we were able to refine it to top 75 markers that seem to be most predictive or prognostic of outcome. So we're getting somewhere, but there's so much more to be done. And ultimately, we want this to inform real-time treatment decision-making. So using the predictive analytics to drive patient-centered precision pain care, so that as we're collecting these data, we can actually have what they call sort of like algorithms that can run that allow us in the moment to render treatment decision-making and get that information back to the research teams to kind of further our pain science inquiry and back and forth. The full circle, you might say. And as for what is next, we're going to be launching a study this fall that aims to develop a digital biomarker of the pain experience leveraging Apple Watch technology. There may be some of you watching today who's wearing an Apple Watch or another smartwatch device. These are ubiquitous in our society, and yet we haven't harnessed this technology to support our understanding of the everyday experience of individuals living with chronic pain. This study will be a nationwide effort for young people ages 14 to 25. We hope that we'll have a signature that allows us to track the pain experience to inform care providers, clinical trial response, and the patients themselves. So stay tuned for more on that end. But I wanted to lastly emphasize the importance of partnering with patients in research. Ashley mentioned the Better panel. And this is something that we have really invested a lot of time and energy, and it has returned a tremendous sense of impact and value to the work that we do, and an incredible amount of meaning. So we have individuals with lived experience, not just as participants in our study, but as expert consultants. This panel's now integrated into all of our studies. And the track pain study that I just mentioned, we have 3 key lived experience consultants who are involved in the development of the idea and will be involved in all stages of the research process, from how we recruit patients, interpret our data, and disseminate our findings back to the individuals we hope to help. Okay, now I want to hand it back to the amazing Ashley McDonnell, who we've had the honor to work with over the last 3 years.
Thank you, Dr. Simons. I just want to talk a little bit more about what it's like being a patient partner. And I especially want to emphasize how amazing it is to feel so listened to, because I think it is so common when you're struggling with pain to not feel listened to in a health clinic, whether it's what treatment you want or the symptoms you're experiencing. And so I found it to be so rewarding to have a group of incredible researchers that are making impactful change actually care about my opinions. And so it's been really rewarding for me. And so some of the work that I've consulted on is I tested a discrimination tool for pain. And so I physically sat there with the researchers, tried the tool myself, told them like what I thought was confusing, how I could see it being made clearer to patients before they rolled it out in a trial. And so one of the best things about being a patient partner is that you don't need any background in like scientific literature or anything, because it's truly based on your experience. And so I found that to be really incredible. I have learned so much, and it's been really rewarding for me because I do want to go into the medical field, but it is truly based on experience. And I've also worked on a team that's working to assess physician burnout in integrated pain teams. And so I've helped to analyze data during that. And it's basically like I analyze the data and the researchers do, and then we come together to create like thematic findings. And so it's just been a really rewarding experience. And I've found so much joy in being a patient partner. And it's shown me that while progress in pain research does take a lot of time, there are so many people that truly care about this and have dedicated their entire careers to improving the lives of patients with chronic pain. And so I think as patients, it's an incredible opportunity to ask those hard questions and advocate for what we want to see in pain research. And when we all come together to do this, we're going one step closer to a world where pain does not control as many people's lives. And so I've just found being a patient partner just an incredibly rewarding experience and a way to come together with so many incredible people to all work towards a common goal. And it's really felt empowering for me throughout my own pain journey to see the work that's being done and the future that there is for people with pain. So thank you so much for listening to my experience. And now I think we're going into a Q&A.
Okay, thanks so much, Ashley. I really appreciate you sharing your experiences. So one of the first questions that we have that I think is really relevant for Ashley first, and then Dr. Simons, is how can somebody learn to be part of a clinical trial? How did you learn about it? And then how can more people participate?
Yes, so I'm really grateful that I was already at Stanford's pain team being treated throughout my pain journey. And so they reached out to me while I was in the clinic about participation in multiple trials that I've been a participant in. But I think Dr. Simons would know how it works more if they're not physically in person. So I'll hand that one over to you.
Yeah, I think there's a lot of great opportunities to get involved with research. So clinicaltrials.gov provides an overview of open clinical trials, and it will let you know if they're actively recruiting. We've actually gotten some patients who've reached out to us and have been enrolled as a result of seeing our post at clinicaltrials.gov. Also, there's Research Match, which allows you to kind of fill out a form that that it's about your sort of a little bit about yourself. And then as kind of research studies come online, there's a matching that happens between the research investigator team and the potential individuals who are interested in research. So I think those are a few great ways. I don't know if Dr. Porter, you also have some ideas about ways to get involved in research.
Actually, I have
Yes, I just needed to unmute. Okay. So we do, obviously all of our trials, are currently active trials are posted. So clinicaltrials.gov, as you mentioned. We also have on our website for HEAL a list of clinical trials that are ongoing and are still recruiting. I think that Cindy is going to share that list. We updated it a little while ago before this presentation of what trials are ongoing. We have a panel of people with lived experience that are helping us to communicate better to those outside of the research arena that we would like to really hope that they would engage more in our clinical trials. We're also establishing now, as NIH wide has become more and more connected with engagement of people, not just in the trials themselves, but also in helping to develop the trials and structure the trials, and how, sort of the importance of why we need to engage folks early on when we're putting a trial protocol together. And we have some new communication strategies to reach out to people with lived experience to help us with that.
Thanks, Dr. Porter. So another question, maybe for Laura, any attention to telomeres as biomarkers for pain? Not even sure what that is, but maybe you do.
Yeah, so telomeres. So telomeres are like the little ends on the SNPs of your DNA, from what I think I know. And they can get shorter based on stress and life experiences. So it can be a marker of life stress. It can be a marker of disease state. I know that I know a few colleagues who are exploring work that's been done in early childhood trauma and stress, and trying to apply that same kind of model or lens for chronic pain research. And I know they've been looking at garnering some funding to do that. So I think that it's coming down the pike. I think that, we have so much we can learn from other domains in the field, right? So we recently published a paper that talked about how chronic pain is like a toxic stress, particularly in how often individuals end up feeling fairly isolated, fairly stigmatized, and that sort of chronic stress state that you experience living with chronic pain can have, huge implications on your body and your health status and these biomarkers that we're interested in measuring. So I think that being able to pull from other areas of research that have made breakthroughs in our understanding of how life stress and early life stress can impact the body, and how we can target or intervene, could be incredibly helpful for how we can help individuals who've been living with chronic pain for so long.
Great, thanks, Dr. Simons. I think this one is for potentially Dr. Porter. Is there research being done to improve the standard pain scale? It's so imprecise.
It is very imprecise. And most of the studies that we're doing, the clinical studies, use other options for measuring pain. There are many, many different pain scales, not only in the research arena, but are also showing up in the clinics. So one thing that we have done for our trials is we're requiring a certain set of pain-related, we call them domains, to ask people who are in the trial, like a before and after, to see how the outcomes of the trial affected them. And those include pain severity, the duration of pain, how it interferes with your life. So it goes way beyond the pain scale. The pain scale still does pop up now and then. The other thing that we have done, which we hope in the clinic will be helpful, so this is outside of the research arena, we worked with the Centers for Medicare and Medicaid to pull together pain assessment tools, rather than just a 1 to 10, what's your pain look like right now or feel like right now, that a clinician who's an orthopedist, for example, or a rheumatologist or a primary care physician can go to the website and pick out a short screener. So this will only take a couple of minutes. That could be used in their office, in their clinic, when they're doing an assessment for pain. And it just gives a brief what languages it's available in, how long it takes to administer it. Can you do it with pencil paper? Can you do it in the waiting room? So I think that getting the word out that there are other ways to measure and get those other measures into healthcare records for physicians who are treating an individual can share rather than 1 to 10.
Okay, so this question could probably be for either Dr. Porter maybe first, and then Dr. Simons. How does the outcome of these studies get communicated? We'd very much like to know what the results are, but don't feel connected to that.
That's a great question, and I'll turn it over to Laura in a second. So we're trying very hard through a number of different programs in HEAL that are engaging the communities of people with lived experience about how do they want to hear the results? So we did a survey. I think, Cindy, you were super helpful with disseminating that. Like, how do you want to hear about study results or new treatments, et cetera, et cetera? And so part of our communication plan for the next 5 years, at least through our office, is to begin that process of newsletters or webinars, et cetera, et cetera. Putting the trial outcomes into lay terms is incredibly important. And we have a program through HEAL called Connections, with several different organizations who are helping us as we get study findings ready, write them up in verbiage, language that a person who doesn't have a strong research background can understand, and the best ways to get that out to the public. So I think Dr. Simons has probably got some more specifics related to her study, so I'll turn to her now.
I mean, I think that those cover a lot of the things we've even done within our lab, had students, like as a summer project, create infographics that communicate the findings from our studies. So each of them was like assigned one of our studies and like create an infographic that communicates the key messages. But I would love to hear more from your membership, as you know, how we can enhance that connection. That's why I was incredibly honored and excited to be able to talk today, because I rarely have the opportunity to speak with, you know, large groups of individuals with lived experience about the work that we're doing. So I think that the opportunities are endless, and I'm open to whatever you all say is the best way to do it.
Thank you. That's great. And in fact, perhaps you'd want to share some of those infographics. We could have a place on our website where we're going to have the recording available to, share some of your infographics. Be great. And any other findings, Dr. Porter, that you want to emphasize.
Great.
Lots of questions, lots and lots of questions. Here's an interesting one. Animal models have been shown to be poor predictors of human pain. What is HEAL doing to minimize animal model studies?
Oh, thank you. That's a great question. So we have a brand new program, or almost brand new, called Precision. And this was in response to the community. We need things other than animal models. The behavioral outcomes in the animal testing doesn't match up with humans. Sometimes the pain condition doesn't match up. So we have a new program to use human tissue for some of the early stage. And so this can be tissue that's collected like after surgery, if someone has like a little bit of their spinal cord that has to be taken out from a surgical procedure, or cultures, or just things that are much more, that are human origin tissues rather than animal tissues. That's early. But then also trying to get models in, rather than laboratory animals, to look in veterinary clinics where, the animals are being treated for pain, and sometimes the veterinarians are better educated in how to treat them. So trying to look to those studies to help us better understand, like, communicating with how animals respond to things. And that helps us with people who have communication problems, where we can't get a read on the kind of pain, infants or people who are suffering with dementia. And so those are a couple of different avenues, but the precision, the programs using human tissues is really starting to blossom.
Thank you. That's great. Here's a question for Ashley. Thank you for sharing your story. We appreciate it. What contributions as a patient do you feel we all can give to research to make a difference?
Oh yeah, that's a good one. I think it truly just starts with just reaching out, and that's really how I began. So I was so interested in the sprint study, and I talked to Dr. Simons, and I was like, I want to be involved. And so that kind of sparked the Better panel. And so I think that it's really just personal experience. And I have been able to make meaningful changes just by saying like my perspective on something. And so I think it's hard, but it first starts with involvement. So just building those connections is the first way to be able to make changes. And because I'm starting like before these like trials are rolled out to other participants. And so it kind of starts in the beginning and then the changes like last throughout the entire trial. So I think reaching out to people is really the best way to do it, like right from the beginning of the trial.
Thanks, Ashley. This is for Dr. Porter. Is HEAL studying mind-body approaches? And what about insurance coverage for mind-body approaches? These are often not covered.
Yeah, thanks. I tried to get through some of the questions in the chat. So this one, yes, we're doing a lot of mind-body work through HEAL. So the National Center for Complementary and Integrative Health has been doing a fair bit of mind-body research before HEAL existed. And then they have a program called PRISM, which are pragmatic trials where they look at implementation of successful approaches in a healthcare setting. And so that program is doing, I think, 4 or 5 trials that are all involve mind-body approaches in some way, shape, or form. So there's a lot being done on relaxation and yoga. NCCI did some studies on Tai Chi. Acupuncture has been a big one that doesn't quite fit in that space, but so reimbursement is another issue. And we've worked with the Centers for Medicare and Medicaid in order to determine how to begin. That's a good place to begin the reimbursement process in hopes that the private insurers will follow their example. And so they're now covering acupuncture. We did a study that showed it's effective for low back pain in older adults, which is their primary population in Centers for Medicare. And that some of the challenges there are that the insurance companies, including Medicare, need to have a certification that a provider can do yoga safely, do yoga training safely, or mind body safely. And so this is where we're running into challenges there. So that's not, it's out of our scope for NIH, but we're definitely working with some of our sister agencies to try and make a little bit of headway in that area, reimbursement.
Thank you. And that's one of the things that we at US Pain work on as part of our advocacy program, which is getting insurers to cover other types of treatments for pain, including mind-body treatment. So if you're really interested in that, definitely join our advocacy efforts to try to get individual states, private insurers, because insurance is typically privately covered in each state, to get insurers to cover mind-body approaches. Lots of other questions. Let's see. Dr. Porter, how does HEAL pain research and funding fit in with other pain research and funding at NIH?
Yeah, that's a good question. So HEAL is targeted research. So when we were given money for HEAL back in 2017 to start the program, we depended on a lot of outside opinions from researchers, clinicians, people with experience, and also a research strategy that we had done called the Federal Pain Research Strategy that we called in experts over the course of a year or two to tell us what research was needed. So HEAL research, topical research kind of evolved out of those prior inputs. So we had a strategic plan, if you will. Many institutes across NIH fund pain research that is very relevant to their mission. So example, the Cancer Institute does a lot on cancer pain or chemotherapy-induced pain. Those are all outside of HEAL. The Child Health Institute for Child Health does a lot of pain related to pregnancy or in children. HEAL accounts for much less than half of the dollars spent on pain research across NIH. So there's a big investment. And HEAL tends to be the research that is of interest to many ICs and that are bigger research projects that an individual institute could or would take on. So HEAL is a little bit more collaborative, if you will, but it's less than half the dollar. So there's a lot of pain research outside of HEAL going on at NIH. It's
Great.
all it's in the public database. If people want to hunt a little bit around, it's called Reporter, and you can just click in and put in, a pain condition, and it will text search and tell you what research is going on in there. And that'll be all pain research, not just HEAL.
That's great. I think we'll make an effort to include a link to that as well, because that would be great.
Okay.
We've had lots of questions about individual conditions, and we won't be able to address all of those, but for sure. Here's one for Dr. Simons. Can you elaborate on immunology markers? What are they?
Yeah, so the inflammatory or immune markers that we used in this study, I had in the slide a few, it was like the IL-6 and IL-2 and a few other kind of common immune inflammatory markers that have been kind of identified in other works. So the way that we looked at it was a little bit unique in that it's oftentimes you're looking at sort of a marker, and it's you're taking a blood test and looking at the status of the marker. But we in our study actually did something where we looked at it kind of stressed, like if you can stress a blood sample, that's kind of what we did. That allows us to look at how that marker responds to bodily stress. And so that gave us a more sensitive way to look at the response. So that's kind of, it's using this technology called CyTOF that is right now very expensive to do in kind of research, but it's one of these things where if we can discover things in this more expensive context, then we can translate them into a simple blood test in the clinic. So I think that, some of the work that we have to do on the front end can be a little bit more complicated than it needs to be in the clinic. But that's kind of some of the markers that we're looking at now to see how essentially those immune markers respond to kind of stress. And those were some of the items that were kind of hits in the work that we did. And, obviously when we go to like publish our outcomes, we'll have kind of a more detailed analysis of each of the markers and things like that. But I'd have to give a whole other talk just on the immune markers to get into all of that, but it's a great question.
Thank you. Here's one for Ashley. What tips do you have for people participating in trials to communicate or collaborate with both the study researchers and their own doctors about making sure the study fits with their existing pain management plan and treatments? Good question.
Yeah, that's a really good question. I think for me, it was pretty easy because I was being treated at the same place where the research was ongoing. But I think that when you're first being determined to be eligible, they look at like how long you've been experiencing pain for, some other markers of pain or like age. And so you'll like be determined to be eligible. But I think, as I mentioned before, when you're participating in research, you don't necessarily get benefits in a treatment sense. It's more for like long-term knowledge, especially on like rare and neglected diseases with pain. And so I think Dr. Simons might know about this too, but when you're doing the trial, it's more to like benefit in the long term than combining with like treatment options. So you should definitely still like be under the care of a pain team at the same time. Hope that kind of answers the question. I don't know if Dr. Simons wants to take some of it too.
No, I think that's very, very accurate. So for example, the SPRINT study is one that doesn't involve a treatment or an intervention. It's one where we're measuring different features of the individual patient and their experience, and then using those features to help us understand long-term outcomes. So there's no intervention per se. We do have other studies where we individuals enroll as part of a clinical trial where there is some, potential benefit. But these are clinical trials, so, they're being tested. So it's this really challenging process where, we really rely on individuals to trust us that we are, trying to develop the best care and options for them, using, taking care to kind of burden them in the least amount, to try to get the best outcomes. But there really is that trust that needs to be there in order for an individual to choose to be a part of a clinical trial. And that's something we have to earn, because there's been so much, mistrust that's been cultivated in the medical system, because of, as we talked about, the windy roads to a diagnosis or a number of treatment options that have really failed along the way. So we really value building that trust and ensuring that individuals feel like they're well informed of what they're getting involved with when they sign up for a clinical trial. And ultimately, we do hope that they benefit to some extent from their involvement.
Great. Here's one I think for Dr. Porter. So U.S. Pain Foundation and other organizations are championing a bill in Congress that would improve population health data on pain. How would better data possibly drive better pain research, better population health data?
So I think the current population health data tells us that we need more research at that level. Is a huge problem. We have some questions involved in the larger surveys, national surveys. One is called the National Health Interview Survey. And those types of surveys reach out to 20, 30,000 people per year. And they repeat the questions over the years. So you can see how population levels of reports of chronic pain or high impact pain change over the years. And so a couple things that's told us that the prevalence of pain is high, but also that increasing numbers of people are reporting chronic pain. But there are only a few questions in there. So that survey and many other surveys are very carefully curated as to what questions can go in. It's expensive to validate the questions to get them in there. So I think it would be helpful to ask more questions that are more targeted. For example, how does it affect care providers for people who live with chronic pain, or their families or their colleagues, and how it affects them on a more lifestyle level, if you will. The questions are pretty generic right now. So I think the surveys could be expanded a bit, but there are a lot of questions that are asked about all kinds of different health conditions in those surveys. We had a researcher at NCCIH who has spent his entire career looking at population health research. And it's more about reporting out what the status is, but not what the needs are. And that's maybe where we need to delve in a little bit more. Like, what do we need to improve the situation, and how do we get at that? There are people that know how to write those survey questions better than I do, but what would make your life better kind of questions. And so I mean, Cindy, you know that bill in greater detail than I do, and I think it's really important that we do look more deeply rather than who reports pain, how many people report pain, and over how many years. It's a little bit simplistic still.
Yep, even the demographics, like the one study that we had that came out in April showing that the native population has much more pain than Caucasian population. We knew there were disparities, but that was a particular, the Alaska Natives and Native Americans was a really interesting study. What's being done in the Indian Health Service, for example, to address pain, because that's such a big problem. So that's the kind of thing that data can help us. That data go ahead.
That data is really useful for driving big programs. So there's a huge program that's just starting up for Native Americans to build their research resources to address OUD and pain. And so we worked really hard to make sure that pain was in there. It's a HEAL initiative. And the first couple of years we'll be building research resources, understanding how to share the data across the different experiments or studies that go on that the tribal nations decide to run. So it'll be up to them what research they want to do and what they think is important. Pain is a big part of that. And so you're right, it's huge in that population, huge problem.
Great. So that's just one example but there's lots of data that bill would collect that would be, I think, incredibly important for research and pointing directions. So thank you for whoever asked that. There are many more questions, but I think we probably have time for one more. What is HEAL doing to keep their studies patient focused? Is the last one.
I missed just the last couple words in that, Cindy. Could you run it one more time?
What is HEAL doing to keep their studies patient focused?
Aha. So we are trying harder and harder all the time to have patients, actually people with lived experience before they become patients in our studies, to help us design the study. We have a HEAL has a community partnership committee that has told us many things that we need to do better. And so we're trying to launch some of those things, like training people to be involved in advisory boards for trials. What's the language we need to learn? How do we deal with scientists who are always talking in scientese? And what kind of things do we need to know before, like how is a trial designed? How is it reviewed? How do we implement it? Those are some of the things that we're launching now from many different directions, from NIH, from the pain field, from the OUD field, and I hope that that will be helpful. And then we are asking our HEAL investigators, when they write their applications for HEAL dollars, to include in there a strategy for better engagement of people with lived experience, and better recruitment strategies to make it easier. I think Ashley's put a lot of great examples out, easier to be in a trial and to get through some of the challenges. So we're getting a lot of things going, and so I hope that will be helpful.
Great, thank you so much. So this has been a really great discussion, and we have so much participation from the audience, so many questions. So thank you, participants, for giving us all these questions and for maintaining this interest. And I want to especially thank Dr. Porter, Dr. Simons, and Ashley for presenting today and for your hard work and your dedication to helping people with chronic pain. Your audience really appreciates it. I think it gives people a lot of hope that there will be better treatments in the future. So thank you so much for all that you've done for people with pain and continue to do. And then we will make an effort to put any resources that we've mentioned today on a page on our website where we will have a recording of this, so people will be able to listen again to anything that you might have missed. And then remember to check out our free resources on Pain Awareness Month activities. For the rest of this week, we only have one more week of Pain Awareness Month, but anytime US Pain Foundation activities are always on our website. So thanks again for your participation, and we really appreciate it and hope to do more with NIH this way. Bye-bye.